Right. So today we will finish off gastroenterology. And today the questions are focused on liver disease. Okay. So let's go. Ahead on it.
Yes, sir.
Okay, fine. Right. Now the first few questions are focused on jaundice. Right. Now in your long cases, when we did jaundice, I explained in detail how you classify jaundice based on clinical type and the various changes and investigation abnormalities that you can use to detect these various types of jaundice. Right. So I'm just going to quickly revise that. Detail kata karanna hai. Okay. We remember that my table in your long cases. So essentially, when you take jaundice clinically, you classify it to three main types. Ne? So you have prehepatic jaundice, where the problem is before the liver. Okay. Hepatic jaundice, where the problem is within the liver, and post-hepatic jaundice, where the problem is post-liver or after the liver. Post-hepatic jaundice is also referred to as obstructive jaundice, right? And that is mostly a surgical problem. And may table like a mataka. We also divided hepatic jaundice based on the pattern into two further types. Okay? So hepatic hepatocellular jaundice kinekai, hepatic cholestatic jaundice kinekai. The main difference for these two are that in hepatocellular pattern, you will see a predominant injury and death of hepatocytes. That is the predominant pattern that you see in a hepatocellular jaundice. But in a hepatic cholestatic jaundice, what you see is predominantly bile getting stuck in the small microcanaliculi of the liver. Okay, so it is also an intrahepatic cholestasis. So this is the main classification of jaundice clinically. In the long case. And for each of these, you need to know the clinical differences, right? What type of bilirubin is elevated, what happens to urine urobilinogen, urine bile, transaminases, ALP, and what happens in the ultrasound scan. One make a detail kata in the long case. Right? So please revise that, and it's very important for long case, important for MCQs. So let's go through the MCQs and now try to discuss and remind ourselves of some of these concepts. Okay, true or false regarding cholestatic jaundice. Now, broadly, cholestatic jaundice can occur due to bile stasis. That is what it means, cholestatic jaundice. Bile stasis can occur due to a problem inside the liver due to a micro obstruction in this very small, minute bile canaliculi within the liver, or this might be a problem of obstruction outside the liver. Right. Right. Now, cholestatic jaundice, the typical clinical picture you see is very deep jaundice, right? Dark urine or plain tea colored urine, very dark orange colored urine, right? And they will have pale stools. That is a typical picture. And another very important feature is this bile gets deposited in the skin, causing intense pruritus, right? Cholestatic jaundice is known to occur in patients with viral hepatitis. Viral hepatitis. Now, viral hepatitis predominantly causes a hepatocellular type of jaundice, but with time, right? So as the viral infection starts to resolve, you might see a cholestatic phase. In viral hepatitis A, B, and sometimes C, you see a initial hepatocellular jaundice, hepatocellular pattern, which later transforms into a cholestatic pattern. And this is sometimes called the cholestatic phase of viral hepatitis. By this time, the virus has gone most often, right? It's just a prolonged injury process that is occurring, right? And that causes a cholestasis. So viral hepatitis, predominantly there is hepatocyte injury, death, but they can have a cholestatic phase after that. So that is true. That is true. Right? But remember, cholestatic jaundice is mostly due to biliary problems inside the liver, outside the liver. inside the liver, you can have these various autoimmune biliary diseases, primary biliary cirrhosis, autoimmune biliary diseases. Those are postgraduate. You don't need to worry too much about those. Okay. Now, what type of bilirubin is elevated? So what happens is, in cholestasis, there's no problem with bile conjugation. There is no problem with bile conjugation. The problem here is excreting the conjugated bile. So they will have a high conjugated bilirubin, high conjugated bilirubin, or high direct bilirubin, high direct bilirubin. Conjugated bilirubin means the same thing as direct bilirubin, as you know. Right? So indirect hyperbilirubinemia is characteristic causes a direct hyperbilirubinemia. Right? And you also know that the urinary urobilinogen is absent. Why? Because there's no way of excreting the conjugated bile into the gut to form urobilinogen. Right? So urinary urobilinogen is absent. Right? The color of the urine here is given by bilirubin diglucuronide, right, which is regurgitating back into the bloodstream, right? So all this conjugated bilirubin in the liver, right, there's nowhere for it to go. It regurgitates back into the bloodstream because it's very water soluble and is excreted in the urine. So that is bilirubin diglucuronide. Remember, bilirubin diglucuronide and urobilinogen are two different substances. Right? Bilirubin diglucuronide and urobilinogen are completely different substances. Urobilinogen හැදෙන්නට gut bacteria වල පොඩි change එකක් වෙන්න ඕනේ. නැත්තම් ඒක වෙන්නේ නැහැ. ඒක හැදෙන්නේ නැහැ කියන එක. Okay? And then another thing we mentioned was, remember that cholestatic jaundice, the primary problem is in the bile canaliculi, in the bile system. Right? So what you see is a disproportionate rise in the biliary enzymes compared to the transaminases. So disproportionate rise in the biliary enzymes like ALP, gamma GT, or there's another one called 5-nucleotidase, right? These are the enzymes that are disproportionately elevated, not the transaminases, not the transaminases. Sorry, not the transaminases. Okay, right. Deranged PTINR is associated. Yes, that is important to remember, right? Because remember, this bile is very important in absorption of vitamin K as well, and they get PTINR derangement because of vitamin K related problems. Right. Okay, so this is important. Another way that you can have deranged PTINR is with time, if the cholestasis does not settle and becomes chronic, the patient can have liver dysfunction as well, and they can progress to cirrhosis. And that is another way how your PTINR can be deranged, right? Because remember, the liver produces a lot of clotting factors, and the liver fails, it cannot produce these clotting factors. So, I make a detail katakara in the long case, but obviously you will expect MCQs also from these same concepts in your paper. Right? So, this MCQs on cholestatic jaundice. Right. මේ table එක ඔළුවේ තියාගන්න මතක තියාගන්න, you need to know very clearly how to fill this out, how to differentiate between the various types of jaundice, right? Various types of jaundice. So things towards the right side, cholestasis and hepatic cholestasis and post-hepatic all cause a direct hyperbilirubinemia, whereas pre-hepatic jaundice is an indirect hyperbilirubinemia. Hepatocellular is a bit of a mix, right? It's a bit of a mix. It's difficult to say what exactly it is. Okay, now the next few questions are on cirrhosis, right? So essentially, the pathogenesis of cirrhosis, put very simply, Lamai, is that there is some liver insult, and the liver insult can be various things, can be alcohol, can be autoimmune disease, whatever it is, right? Or metabolic liver disease, whatever it is. There is a liver insult, right? There is a liver insult, and there is this interesting cell which lies in what is called the space of Disse, right? That is very adjacent to the hepatocytes and the blood vessels. Space. You can see the hepatocytes in this layer and the blood cells. This is the endothelial layer. And in between that, you have this space of Disse. You have this stellate cell. Stellate cell is a very special cell. And now we know that in cirrhosis, what happens is this liver insult, whatever factor, activates these stellate cells, right? Activates these stellates. So the primary problem is activation of stellate cells, right? And when these stellate cells become activated, they start to produce a lot of collagen and sort of fibrosis related materials, right? And that is the sort of pathogenesis in a very simplified manner. So activation of stellate cells is what we think is the primary problem in cirrhosis, right? That is the pathogenesis or the pain problem that we see, right? All right. Now, in this next MCQ, I think mostly I'm asking you about mechanisms, etiology වගේ ප්‍රශ්න තමයි මෙතන අහලා තියෙන්නේ. Right. So we've already discussed second MCQ to second statement, pathogenesis is mediated by activation of hepatic stellate cells, right? So that we know as true, right? That is so whatever insult causes these stellate cells which are sleeping or quiescent in more scientific terms to get activated and start secreting a lot of collagen and other sort of fibrosis related materials. And that is the problem in cirrhosis. Right. Now, when you take etiologies, the next slide gives you a whole list of etiologies, and it also gives you the definition of cirrhosis, right? So remember, cirrhosis is predominantly a histopathological diagnosis. The word cirrhosis means essentially there is fibrosis causing hepatic architecture to be distorted. This distortion of the hepatic architecture. And there are some areas of regeneration, which form regenerating nodules. So in this picture, these blue sort of things or sort of cyan colored things are the fibrotic bands within the liver. And these are the regenerating nodules, right? The ones I'm circling with the laser pointer, those are the regenerating nodules. Right. So there is fibrosis, there is distortion of hepatic architecture, and there is formation of regenerating nodules. Now, what is useful for MCQ sometimes is to know pathologically some causes of cirrhosis from a macronodular picture, right? Macronodular, and some form of micronodular picture, right? Now, alcohol causes a micronodular picture. The nodules are small, the regenerating nodules are small. Of course, you can get macronodular in late stages sometimes, but mostly alcohol is micronodular, right? But things like viral hepatitis are macronodular, right? That MCQ, and this table is important for some MCQs as well. Right, and here you can see the nodules here in a pathological specimen, right? Take a pain over. So macronodular cirrhosis is typical of alcohol නෙවෙයි. Typical alcohol where typical is micronodular cirrhosis, but remember in late stages you can have macronodules also, but typical like a micronodular cirrhosis. So 3 is false. Right. Then I think I have also. So this gives you a nice summary of the etiology. මම මේ slide ටික බලාගෙන යන්න විභාගයට කලින් මෙතන summaries වගේ ඔක්කොම තියෙනවා එකේ කෝණුනේ වල. හරි. Right. So the etiology of cirrhosis can be alcohol, infection, metabolic, autoimmune. So just please remember these. Long case ekut api discuss kara, and sometimes you have biliary tract diseases also, which are mostly autoimmune, which cause cirrhosis. Right. Now, we will talk about hepatitis later in the discussion, but remember, hepatitis E does not cause cirrhosis. And that is quite clear that it does not. A and E mostly cause acute hepatitis and do not cause cirrhosis. It is B, C, and D that cause cirrhosis, right? B, C, and D. D is a funny fellow that always needs to coexist with B, but don't worry too much. Those are advanced concepts, right? So, but remember, B, C, D are the ones that cause cirrhosis. And of the three, C, they are lazy. Hepatitis C has the strongest risk of a patient going into cirrhosis. If you have hepatitis C, there's a strong risk of developing cirrhosis. Okay, fine. So, 1, 2, 3, done. Right. Now, when you have cirrhosis patients, if you take the investigations, remember cirrhosis, when you get cirrhosis, you get portal hypertension. Portal hypertension is one of the key complications of cirrhosis. And portal hypertension causes a lot of other problems like ascites, NSBP, portosystemic shunt anastomosis like gastric varices opening up, hepatic encephalopathy, hepatorenal syndrome, and various other problems. So the main problem is that in cirrhosis, you get portal hypertension. The portal vessels are all obstructed and thada වෙනවා. හරි? ඔක්කොම thada වෙනවා. Right. Okay, fine. Now, if you take investigations in a patient with cirrhosis, all of you know that the synthetic functions of the liver will be impaired, right? Synthetic functions. And then because of that, their albumin will be low, right? And also that one of the very sensitive indicators of hepatic function is the PTINR, right? That will also be abnormal. So low albumin and high PTINR are quite commonly seen. But of course, the other liver functions like bilirubin will go up with time. And also the transaminases are not very high, but they're slightly elevated, right? Make MCQ වලට අහනවා. They are slightly elevated. The AST is higher than the ALT. AST is usually higher than the ALT, but it's not thousands. නිකන් 100ක් 150ක් වගේ පොඩ්ඩක් වැඩි. Not very high. Not very high. Right? And as you know, as a result of the portal hypertension, they get splenomegaly and hypersplenism. So they can have pancytopenia, thrombocytopenia, මේක ගොඩක් කතන්දර තියෙන්න පුළුවන්. Right. So remember, key point to remember, cirrhosis portal hypertension is the main complication because the portal vessels run through the liver. They are all constricted because the fibrotic bands are running on top of them. So portal hypertension, and then that gives rise to a certain set of abnormalities, complications. And then these are the laboratory problems that you get. Poor synthetic function, albumin low, PTINR high, transaminases are slightly. 4 is wrong. It is the other way around. AST is higher than ALT. Serum albumin is low. So remember, transaminases are not in the thousands. So they are usually slightly above their normal. Right? And in that you see AST higher than ALT. That is there is a reason for that. It comes from a different set of hepatocytes, the two enzymes, right? So Right. Any questions so far? So Sajid asking, can anti-TB drugs cause chronic hepatitis? Yes. So anti-TB drugs can cause acute hepatitis or chronic hepatitis. If you don't detect the acute hepatitis, it can progress to chronic hepatitis. But I have never seen anti-TB drugs causing cirrhosis, right? Chronic hepatitis can be cirrhosis. There is some inflammation going on, but there is no established cirrhosis or fibrosis, right? And you might be able to reverse it to normal also sometimes. Right? But it can cause they can cause chronic hepatitis. Okay. Right. Any other questions?
So what are the other hepatitis that are more predominant with cholestatic pattern? Is alcoholic
usually causes a hepatocellular injury acutely, but sometimes can cause a cholestatic also. Right? But acutely, it is a hepatocellular thing that can happen. Viral hepatitis, autoimmune hepatitis again is mostly hepatocellular, right? Except for the autoimmune biliary diseases, which are mostly cholestatic. And I think in the long case we discussed, certain drug-induced hepatitis are cholestatic, like an antibiotic-induced liver disease. Those are sort of things like coamoxiclav, they cause cholestasis and cholestatic hepatitis.
Thank you, sir. Can we call alcoholic hepatitis as a cause of deep jaundice?
Yes. Alcoholic hepatitis sometimes causes deep jaundice. Yes.
Thank you, sir.
Remember, deep jaundice can occur in hepatocellular also. Right? But alcohol mostly causes a hepatocellular pattern, but it can cause a cholestatic also sometimes. Hari. Okay, right. Now, as I told you, portal hypertension is a main problem in cirrhosis. It is one of the key problems, right? And because of obstruction of the portal system within the liver, you get opening up of portosystemic anastomosis. Because the portal blood needs to go somewhere else. It's not going through the liver, right? Before that, can non-alcoholic steatohepatitis cause very rarely. Non-alcoholic steatohepatitis in the early stages does not cause jaundice a lot. Liver can enlarge, but jaundice rarely. Cirrhosis, obviously you can get. Right. So there is opening up of this portosystemic anastomosis, and then you get various complications because of that, right? Like varices, splenomegaly, ascites, and hepatic encephalopathy, right? Hepatic encephalopathy specifically because the portosystemic anastomosis that are opened up carry ammonia directly to the systemic circulation. Right. So just a little discussion of this now. So as you know, in cirrhosis, I told you that there is architectural disturbance, and that leads to increased hepatic resistance, right? There are other factors also that contribute to increased hepatic resistance. For example, there is a sort of vascular contraction, right? As that also occurs because of cirrhosis, right? So you get portal hypertension, I told you, because all the portal vessels are constricted and there is increased hepatic resistance because the fibrotic bands are trapping the vessels inside. Portal hypertension as a reflex leads to splanchnic vasodilatation, right? That leads to splanchnic vasodilatation. And splanchnic vasodilatation is the main thing. Make a look at detail that I got known as splanchnic vasodilatation is the main thing that leads to ascites, right? That's the main thing that leads to ascites, because when you have splanchnic vasodilatation, the systemic blood is diverted into the splanchnic circulation. Splanchnic can look vessels ගොඩාක් එතන තියෙනවා. When there is splanchnic vasodilatation, the systemic vessels all drain into the splanchnic circulation and they get peripherally hypovolemia, right? Hypovolemia, and that activates the renin, angiotensin, aldosterone system. And this is one of the main contributors to ascites, right? Main contributors to ascites, right? So, at the moment, portal hypertension leads to splanchnic vasodilatation, right? That's a reflex mechanism. And then splanchnic vasodilatation causes pooling of blood in the splanchnic circulation, depleting the peripheral volume. When the peripheral volume lemma is depleted, that causes, and as you know, activation of renin, angiotensin, activate. Right? And that is one of the main contributory factors to ascites. Okay, right. Right. So a few more MCQs on cirrhosis and cirrhosis-related complications. Do we go further invest in normal AST? I don't quite understand the question.
Sir, if the AST and ALT in the normal range, but AST more than ALT.
No. That is not a problem. Yeah, you will obviously repeat it and monitor it, but you don't have to do any further things. Yeah. Okay. Charaka, no, there is no definition for deep jaundice. It's just clinically that you see him a definition. Correct? Okay, right. So let's move on with these MCQs now. True or false regarding cirrhosis? And so I think most of these questions, yes, are regarding ascites. Ascites pathogenesis that is mainly the splanchnic vasodilation due to portal hypertension, which causes peripheral hypovolemia, which leads to activation of the renin, angiotensin, aldosterone mechanism and leads to ascites. That is the mechanism. Right. Elevated SAG in acidic fluid, diagnosis of bacterial peritonitis. Now remember, when you have a patient with ascites, we discussed this in the long case, you do a diagnostic aspirate, diagnostic aspirate. And like in a pleural effusion, you have an exudate-like thing where there is high protein and transudate. Now, how you judge that? In pleural effusion, we said that it was Light's criteria. In acidic fluid, you do it in a different way, which is called the serum albumin to acidic fluid gradient. So if it's transudate, acidic fluid albumin should be low, and that widens the SAG. If it's exudate, so remember serum albumin minus acidic fluid albumin. So if it's exudate, the acidic fluid albumin or protein goes up, and that narrows the SAG. So elevated SAG spontaneous bacterial peritonitis because in bacterial peritonitis there is a increased amount of protein in the stick fluid, so there will be narrow sag. Okay, so somebody is asking, yeah, so mechanism of ursodeoxycholic acid. So ursodeoxycholic acid increases the excretion of some of this bile and sort of detoxifies some of the toxic contents, right? That's what it does. Right. So SAG, acidic fluid, ekapalenika වැරදි. Large volume therapeutic paracentesis should be accompanied by albumin replacement. So how you manage ascites is, කොහොමද manage කරන්නේ ascites? You manage ascites very simply by diuretics, අපි කතා කරා spironolactone, furosemide diuretics. You can also tap and do a therapeutic paracentesis. But remember, if you are removing 4 or more than 5 liters, remember to replace albumin. 4 to 5 liters already අයින් කරනවා නම් replace it with albumin, right? So that is true. And then I told you that if there is refractory ascites, an option might be TIPS, right? TIPS, right? To reduce the portal pressure, you create an artificial portosystemic shunt, right? And that reduces the ascites. TIPS. හැබැයි මම ඔයගොල්ලෝ long case එකේ මේක කියලා දුන්නා. TIPS වල mainly කරන්නේ මොකද්ද? Yeah, so it causes artificial portosystemic anastomosis. So it is contraindicated if a patient has hepatic encephalopathy or a history of hepatic encephalopathy. Very contraindicated. Because obviously if you're creating artificial portosystemic shunt, අර ammonia එක ලස්සනට යනවා. කිසි කරදරයක් නැතුව යනවා brain එකට. So TIPS is the treatment for all patients. වැරදි. Refractory ascites, TIPS is an option, but it is contraindicated if the patient has hepatic encephalopathy, right? Or had a hepatic encephalopathy in the past. Right. Okay. Then I told you that SBP is a complication of ascites. Again, we discussed it in the long case, treated with cephalosporins. And remember, I told you this again, SBP, even if they have had one episode in the past, you need to give them lifelong prophylaxis. එක episode එකක් හැදිලා තිබුණා, lifelong prophylaxis දෙන්න ඕනේ. Lifelong prophylaxis. We use norfloxacin most of the time or cotrimoxazole as prophylaxis. So, එක episode එකක් තිබුණත් lifelong prophylaxis. That's important. Right. I'm going to leave out the fifth one, right? Because this type 1, type 2 hepatorenal syndrome කියන වචන දැන් වැඩි පාවිච්චි කරන්නේ නැහැ. Right? So they are not going to ask you about type 1, type 2. These words are slightly out of date. So forget about hepatorenal syndrome. Only thing you need to remember is there's an acute variety and a chronic variety, right? Acute variety or a chronic variety. Acute variety, the treatment is fluid albumin resuscitation and terlipressin. එච්චර විතරක් මතක තියාගන්න. හරි. So you give fluids, mostly albumin, fluids and albumin and terlipressin for type 1 hepatorenal syndrome. Type 1 කියන වචනයෙන් පාවිච්චි කරන්නේ there's a acute and a chronic. Acute kidney injury, chronic kidney injury වගේ acute chronic කියලා තමයි ඔක බෙදන්නේ. It's a bit complicated, so don't worry about too much. ඒවා postgraduate වලට ආවම ඉගෙන ගන්න පුළුවන්. Hi, okay. So that is about ascites management. Kavind is asking, can TB cause hemorrhagic ascites? Not commonly. Hemorrhagic ascites is mostly to malignancy. TB wala hemorrhage enne කලාතුරකින්, right? Of all what I've seen, right? It's not a very common thing, but can happen, obviously. Malignancy වල තමයි ගොඩක් hemorrhagic ascites එන්නේ. Okay. So any questions from ascites? So this is a picture of TIPS procedure. So you're creating an artificial shunt between the portal system and the systemic circulation.
Sir, මේක අර first එකේ elevated sag නැතුව narrow sag එකක් තිබ්බනම් ඒකටත් අර වෙන හේතු ගොඩක් තියෙන නිසා
ඒත් වැරදි. Yeah.
true කියලා ගන්න බෑ නිසා.
බෑ මොකද SBP is diagnosed based on a narrow site, SAG ascites, plus you need to demonstrate high white cells in the acidic fluid. That is the definition. Right.
Thank you, sir.
Right. Rifaximin is a prophylactic drug. So rifaximin is used for hepatic encephalopathy prophylaxis, right? Not for SBP prophylaxis. Right. Now, the next problem we are going to talk about is, and the MCQ is based on hepatic encephalopathy. So, ඔගොල්ලෝ දන්නවා මෙතන mechanism එක සරලව. So, ammonia is produced by gut bacteria, right, and enters the circulation. Usually, this ammonia is detoxified in the urea cycle in the liver, but now in cirrhosis, there is no urea cycle. It's packed up, it's not working because of the liver dysfunction. And also, there is a portosystemic anastomosis because of portal hypertension. And so, this ammonia is nicely diverted into the brain through the blood-brain barrier. Right. In the brain, there is this ammonia causes swelling of the brain, right? Direct neuronal toxicity and increased intracranial pressure. So there is swelling, neuronal damage, and increased intracranial pressure. There is also, it alters all the neurotransmitters in the brain, right? Again, mainly GABA වැඩි වෙනවා. Gamma amino butyric acid. Gamma amino butyric acid increases. Another amino acid that increases is glutamine, right? Glutamine. Gamma aminobutyric acid, as you know, is an inhibitory neurotransmitter. Inhibitory neurotransmitter. And all the brain goes nonsense, everything. So all there's a lot of inhibitory neurotransmitter increase, right? Tava goda complicated එක සෙල්ලම් වෙනවා. ඒක ගැන ලොකුවට දැනගන්න ඕනේ. හරි? True or false regarding hepatic encephalopathy? Now, I told you in the long cases that the earliest feature of hepatic encephalopathy, earliest clinical manifestation is personality change. That is the earliest clinical manifestation. Personality ka වෙනස් වෙනවා, හැසිරීම වෙනස් වෙනවා. Then they get altered sleep-wake cycles. So those are the 1 and 2 changes, altered sleep-wake cycles. So personality change, altered sleep-wake cycles. In examination, constructional apraxia is something that you can elicit. Constructional apraxia. 5-pointed star exam. If you get a patient with liver disease, always ask them to draw this 5-pointed star. So constructional apraxia. That is a feature, yes. Hepatic encephalopathy can be precipitated by a lot of things. Slide but essentially, you know, electrolyte imbalances, especially hypokalemia. So second statement is true. Infection, gastrointestinal bleeding, right? Overaggressive diuresis and dehydration. These are some of the common precipitants. Overaggressive dehydration, diuresis and dehydration, hypokalemia, electrolyte changes, hypokalemia and hyponatremia. Then gastrointestinal bleeding, infection. All of these can precipitate hepatic encephalopathy. Right, all of these can precipitate it. And also, if you take sleeping tablets, benzodiazepines, right? Benzodiazepines, that is also a precipitant. So, benzodiazepines. Now, hepatic encephalopathy diagnosed clinically, as I told you, you don't need to do any investigations for it, right? But I told you that you can get these triphasic slow waves. Laser point triphasic slow waves. You can see that on the EEG, so that can be an MCQ point. Triphasic slow waves in the EEG can be seen, right? Remember, ammonia levels are non-specific, right? This because the serum ammonia is elevated doesn't mean that you can diagnose encephalopathy. They are high in most people, but a test it is you don't need that for the diagnosis. It's not specific for the diagnosis. Right. How do you treat encephalopathy? Hari? How do you treat encephalopathy? Mainly bowel opening, lactulose. Mainly karannone. In patients who had a past history of encephalopathy, rifaximin is effective. Right. Statement rifaximin is mostly effective in patients with a past history of hepatic encephalopathy. That is the proper way the statement should be worded. Sorry, so the thing that you need to know is rifaximin and metronidazole also to a lesser extent is better when you have had a past history of encephalopathy. It's mostly a drug that prevents encephalopathy, right? And if you have a past history of encephalopathy, that is the evidence, right? Rifaximin. It's mostly effective in patients who have had a past history of encephalopathy, right? That is, remember. If you don't have rifaximin, you can give metronidazole also. Right? But rifaximin is the preferred guideline recommended drug now. And you know that rifaximin, what is there, is kills the gut bacteria off. Right? Lactive dose are very important. Those are probably more important. And also reversing the underlying cause. Right? ඔය තව පොඩි MCQ එකක් අහන එකක් තියෙනවා අහන්න පුළුවන් එකක් තියෙනවා මෙන්න මෙහෙම. Now I told you that in hepatic encephalopathy there is a lot of increase of inhibitory neurotransmitters, especially GABA. ඕක නිකන් මේ benzodiazepine overdose එකක් වගේ ළමයි. What happens in hepatic encephalopathy to the brain is something similar to what happens in a benzodiazepine overdose. So some people have now used flumazenil drug in health, flumazenil, right? And that can reverse the encephalopathy. But remember, the problem with flumazenil is that it is very short acting. So again, do not a vedak na. Eka patas kala reverse vela arit pattata harena. Right? So eka MCQ ma eka dakka koheri ahala tiyena mata mataka naha koheda kiyala. Flumazenil can reverse the sort of transiently reverse the features for maybe a few minutes to 15-20 minutes either, right? Research කරනවා ඒගොල්ලෝ flumazenil ගැන ගොඩක්. But at the moment it's too short acting to use therapeutically. But it has been known to reverse the effects of all the clinical manifestations of encephalopathy. But because flumazenil, as you know, is a benzodiazepine overdose. So in encephalopathy, what happens in the brain is quite similar to what happens in benzodiazepine overdose. So gamma aminobutyric acid වගේ වැඩි වෙනවා. Right. So that is about encephalopathy. Right. Any questions about encephalopathy? So Pipuni is asking an important question. Lola in hepatic encephalopathy. So Lola has sort of lost its evidence over time. So ඒ දවස්වල නම් ගොඩක් දුන්නා අපි. දැන් එහෙම ලොකු evidence එකක් නැහැ ඔක වැඩ කරනවා කියලා. So we don't usually give it. Right? අපි වැඩිය දෙන්නේ දෙන එකක් නෙවෙයි ඒක. Lola කියන එක. So rifaximin lifelong දෙන්නේ නැහැ. We give it for a certain period and then depending on how things go, you can stop it. But ඒ වගේ decision should be made by a specialist, right? Hari. Any other questions? Okay.
Sir, this is regarding hepatorenal syndrome.
Mm-hmm.
Sir, should there be cirrhosis to cause hepatorenal syndrome, or if there is partial functional impairment, can it cause hepatorenal syndrome?
No, hepatorenal syndrome occurs in cirrhosis patients. If it's not cirrhosis, it is called various other things.
Okay, sir, thanks.
Right?
Thank you, sir. In the they said in the objective jaundice, they are just talking about the hepatorenal syndrome.
No, that is due to a different mechanism.
Okay.
Right?
Okay, sir.
Okay, right. So here we have variceal hemorrhage, and that is obviously a very important complication of cirrhosis. And these are some of the important MCQs that can come. What are the predictors of variceal hemorrhage? So very simple, variceal signs. Red signs, those are mostly found on endoscopy. Right? But these are high risk signs that you see on endoscopy. මහලුකු complicated දෙයක් නෙවෙයි බැලුවම පොඩ්ඩක් ඔක රතු වෙලා ලොකු වෙලා තියෙනවා නම් bleed වෙන risk එක වැඩි කියලා red signs. Child BC is the cirrhosis stage, right? You classify child pew classification කියනවා අපි ඒකට. Right? So these are the risk factors determining the risk of variceal hemorrhage. Right. බලමු MCQ එක දැන්. And we discussed this during emergency medicine classes as well as during the long case discussion. So it will be an easy one, I think. So red sign on endoscopy indicates high risk of bleeding. It is an endoscopic appearance that there is a risk of bleeding in a varix. IV octreotide first line therapy, right? Variceal bleeding wala first line drug එක මොකක්ද? Terlipressin, not octreotide, right? Terlipressin. Okay. So I told you that fluid boluses the definitive treatment is terlipressin and also endoscopy. Right? Those are the two definitive treatment options that we have. You give octreotide only if there is no terlipressin available for you. Right? So it is not first line therapy. Now, FFP katandarekut kiwa. FFP katandarekut kiwa. Now this is very important. Don't give FFP just නිකන් හිතුමතේට, right? That is very important. We don't give FFP to patients with cirrhosis without a very good reason for it. For example, if they have ongoing bleeding with a very high INR, then puluwa, right? But you have to be very careful. There is a reason for this, right? Cirrhosis is a bit of an unusual state. Hari amaru ek predict karanna. Samahalata cirrhosis patients have higher bleeding, right? Samahalata they have thrombosis. It's a very funny thing. Now, several years ago, because cirrhosis bleeding vitarai enne kiyala. But now we understand they have bleeding, but some people have thrombosis also. The reason for that is, as you know, clotting factors and anti-clotting factors all are produced in the liver. They come ahead in okay, right? So clotting factors are also produced in the liver. Anti-clotting factors are also produced in the liver. So actually what happens is whether they bleed or not is based on a balance between this. So some people bleed more because they are more deficient in clotting factors. Some people bleed less than thrombose because they are more deficient in anti-clotting factors. Balance between clotting factors and anti-clotting factors. So you should not give FFP without a very good reason, because you can actually push the patient into thrombosis sometimes, right? So you should be very careful. Yeah, fine. Now, when you have a varicose bleeding in the long term, prophylaxis, how do you prevent them from developing recurrent bleeding? So medically, so prophylaxis, the best thing is endoscopic therapy to prevent recurrences of bleeding, right? Recurrences of bleeding. You use endoscopy. That is the best endoscopic intervention. Second is beta blockers. Carvedilol is now being used often, commonly, and people think that it's better than propranolol. Carvedilol. Nitrates are no longer used. So mainly endoscopy and beta blockers. Actually, a combination of this is very effective. Endoscopy ligate and give the beta blocker. That is much more effective. Chatra, terlipressin, octreotide equally effective. There is new evidence that terlipressin is slightly better than octreotide, right? So it all depends on availability of drugs. Terlipressin is more expensive, and terlipressin is contraindicated if they have ischemic heart disease, right? Now, මේකත් මම long case කරනකොට කිව්වා when they have variceal bleeding, they are at a higher risk of hepatic encephalopathy plus SBP. So the studies show that a person who has had a gastrointestinal bleed has a higher risk of SBP and also risk of hepatic encephalopathy. So you should take precautions to prevent both, right? And for SBP, you should give ceftriaxone, right? Ceftriaxone as prophylaxis. So එතන prophylaxis එකයි අර SBP හැදුනට පස්සේ දෙන prophylaxis එකයි දෙකක්. හරි. In the acute episode when they are bleeding, you should give them SBP prophylaxis with ceftriaxone. Right? Okay. So this is variceal bleeding. Any questions on that? මේක මං කිව්වා. තව important කතන්දරයක් තමයි over transfuse කරන්න එපා කියන එක. මම ඒක long case එකේ emergency එකේ දෙකේම කිව්වා මතක් කරගන්න. Don't over transfuse, because again research has shown that if you over transfuse, bleeding gets worse. ඒතර පොඩි curve එකක් වගේ කො තියෙන්නේ. ඒතර හොඳම around hemoglobin around 8 to 9. Don't aim for a hemoglobin of more than 9, right? More than 9. Sometimes if you over transfuse, they can have more bleeding. Right? ඒකත් මතක තියාගන්න පැහැදිලිව ලියා ගන්න. Do not over transfuse. Okay. Endoscopy වලට there is no specific cutoff. If the patient is unstable, endoscopy is preferred, right? බලබල ඉන්නේ නැහැ ටක් ගාලා endoscopy කරන එක. If you, so most of the time what happens is you treat them medically when they come. If they are on medical management and they suddenly become unstable, people do endoscopy, right? That is the usual way. It happens. I mean, හිතන කමුතුයි කියලා unstable එකම endoscopy වලට safe කියලා, but that is the thing that you do. If you treat them when they come in with medical therapy, and then endoscopy if they don't respond to medical therapy, right? Hari. Any other questions? Yeah, you can use cryopoor plasma, but you have albumin on and then the puluwan nisa එක ලොකු ප්‍රශ්නයක් නැහැ.
So, upper GI bleeding වල patient ව hemodynamically stabilize කරලා නෙවෙයිද යවන්න ඕනේ endoscopy වලට?
එහෙම තමයි කරන්න ඕනේ. But say you've stabilized the patient, medically treated, and then patient suddenly becomes unstable, then you have to do endoscopy. That means the patient is bleeding profusely that you can't control with medication. So it is a judgment. So ගොඩක් වෙලාවට වෙන්නේ when they come in, you stabilize them, medical management කරලා තියාගන්නවා. If they suddenly become unstable again, while you're on medical management, then you have to take for endoscopy. That is how it usually happens. Right. So vascular disease වගේවා for terlipressin are cautions, I think, not absolute contraindications. Even ischemic heart disease, recent ischemic heart disease තමයි main contraindication එක terlipressin වලට. හරි? අවුරුදු 20කට කලින් ischemic heart disease දුන්නයි කියලා ඔක නොදී ඉන්න ලොකු හේතුවක් නැහැ. So recent unstable angina, recent MI තමයි main contraindication. ඉතින් ඔක්කොම එකන් risk versus benefit judgment ඔක්කොම හරි. හරි. Okay, fine. Right. Now that is all about cirrhosis. Now let's talk about other types of liver disease. Now, as you know, alcohol-related liver disease can have a spectrum of manifestations. Alcohol liver disease can just cause a steatosis, right? May figure එක බලා ගන්න. Steatosis become a fat deposition විතරයි, nothing else. Right? Just fat deposition. Okay. චත්‍රප් බෑන්ඩිං ස්ක්ලියරෝතෙරපි දෙකම ගොඩක් වෙලාවට කරනවා. මම දන්නේ නැහැ ඔය දෙකෙන් වඩා හොඳ මොකක්ද කියලා. They usually do both of these things depending on the anatomy of the varix and whatever. හරි. එහෙම විශේෂ වෙනසක් තියෙනවද කියලා මම දන්නේ නැහැ. හරි. Outcomes I don't know. I don't think there is a difference. Right? දෙකම ගොඩක් කරලා බෑන්ඩිං ස්ක්ලියරෝතෙරපි දෙකම කරනවා. හරි. Okay. So alcohol related liver disease, steatosis, right? Fat deposition එන්න පුළුවන්. And that can sometimes progress to cirrhosis. Alcohol on a normal liver can also cause alcoholic hepatitis, right? Alcoholic, which is usually due to severe exposure to alcohol. ගොඩක් වෙලාවට අර පොඩි කාලයක් ඇතුළත ගොඩක් බිව්වම තමයි ඕක හැදෙන්නේ. දැන් සමහර යුන් ඉන්නවා හැමදාම චුට්ට චුට්ට බොනවා. හරි. Alcoholic hepatitis happens, you suddenly drink a whole load of alcohol in about a week or two, that causes acute alcoholic hepatitis. Right? There you have liver cell necrosis, inflammation, and these histopathological structures called Mallory bodies in the histopathology. Right? That is alcoholic hepatitis. Right? And repeated attacks of alcoholic hepatitis can progress to cirrhosis. Right, let's move on then. Right. So just the initial stage of alcohol-related disease is mainly alcoholic fatty liver කියන එක. මේ fat globules මේ පේන්නේ මේ ලොකු සුදු පාට artifacts විදිහට තියෙන fat globules, fat තිබිච්ච තැන්. And they mainly develop this in the centrolobular area. මෙන්න මෙතන liver එකේ. ඒකට MCQ වලට අහන්න පුළුවන්. So this fat deposition in alcoholics is mostly seen in the centrilobular area ළම. මේ මැද near the central vein, centrilobular area එකේ තමයි. And this is the portal triad, as you can see, a portal tract here. Right. Right, sorry. True or false regarding alcohol-induced liver disease? Females are more susceptible, that is true. Sorry. Females la පොඩ්ඩක් බිව්වත් alcohol liver disease හැදෙන්න පුළුවන්. Right? That's a genetic thing. Sorry. Probably related to the enzymes that break down alcohol and things. It's a genetic thing. So females are more susceptible to alcohol-induced liver disease. In alcohol liver disease, I just showed you that the fatty change mainly occurs in the centrilobular area. Centrilobular area. Right? Centrilobular area. දැන් මම පොඩ්ඩක් alcoholic hepatitis ගැන තව පොඩි කතන්දරයක් ඔයගොල්ලන්ට කියලා දෙන්න. හරි. So alcoholic hepatitis, right, mainly in histopathology you'll see these Mallory bodies කියන ඒවා and ballooning of hepatocytes කියන ඒවා තියෙනවා. හරි. They are characteristic but a non-specific feature. So Mallory bodies හැමෝගෙම ඉන්නේ නැහැ. තියෙනවා but they're not specific for alcoholic hepatitis. Hari. I'll come to NASH in the next MCMA slides. Hari. Somebody asked a question for that. Now in alcoholic hepatitis, this is very important. මේක බොහොම වැදගත් මතක තියාගන්න. Alcoholic hepatitis causes an increased transaminase level, no doubt. So alcoholic hepatitis හැදෙන්නේ කොහොමද? If you drink a lot, severe exposure over a short period of time, you can get alcoholic hepatitis, right? So, and of course, as you mentioned, it is a liver injury, liver inflammation, xylem arenum. So elevated transaminase causes mostly a hepatocellular type pattern. හැබැයි මෙතන බොහොම වැදගත් MCQ දෙකක් තියෙනවා එකෙන් අහන්න පුළුවන්. එකක් තමයි AST is more than ALT, right? So in alcoholic hepatitis, AST is more than ALT එක ලියා ගන්න. Usually 2-to-1 ratio එකකින් තියෙනවා. AST is more than ALT in a 2-to-1 ratio. Now, බොහොම වැදගත් එකක් තියෙනවා. The actual levels are not very high. They are not in the thousands. ඒකත් බොහොම වැදගත්. හරි. ඒක හේතුව is unclear, but looking at many sort of studies over time, we have recognized that alcoholic hepatitis transaminases 1000කට වගේ වැඩි වෙන්නේ නැහැ. Interaction rates per liter. It's around 300-400 වගේ. Right? That is also an important thing. Unless, of course, they have taken something like paracetamol with the alcohol or some other injurious agent with the alcohol. Right? Alcoholic hepatitis is an inflammatory process, right? And you get leukocytosis also, right? White cells value. Clinically, you can diagnose it, but sometimes you need a liver biopsy. Sometimes, not always. Sorry, and you will see these Mallory bodies and hepatocyte ballooning. Sorry. Okay. Sorry. So, alcoholic hepatitis is characterized by liver injury and in excess of 1,000, right? Not in excess of 1,000. There is liver injury, but international units per liter 300-400 already very well there unless they have taken something else on top of the alcohol, right? Now, how do you manage a patient with alcoholic hepatitis? You calculate something called the Madri's discriminant function, and that is used to prognosticate people with alcoholic hepatitis. Madri's discriminant function, MDF කියලා කියනවා. ඒක ස්කෝර් එකක් වගේ ළමයි. ඒ ස්කෝර් එක යම්කිසි ප්‍රමාණයකට වැඩි වුණා when it's more than a certain cut off point, steroids දෙන්න ඕනේ. Steroids දෙන්න ඕනේ. Right? ඒව මොනවද cut off points කියලා දැනගන්න ඕනේ නෑ. But in some people, you do give steroids. හරි? Some people. Right. So, Madri's discriminant function is used to prognosticate patients with alcoholic hepatitis. And if it's higher than a certain cutoff, you give steroids. හරි. ඒතර MCQ ටික පොඩ්ඩක් මතක තියාගන්න alcoholic hepatitis ගැන අහන්න පුළුවන් MCQ ටික. හරි. Okay, any questions about that?
So for other etiologies of hepatitis, does that zone differ, that fatty chain zone?
Oh, my කියන්න. ඒ කියනවා. Any other questions? So pentoxifylline is another drug that sometimes is given for severe alcoholic hepatitis. ඒක commonly පාවිච්චි කරන්නේ නැහැ. Antioxidants වගේ දේවල් ඒවා. Sachit is, yeah, alcoholic hepatitis which is not very severe, just supportive management. හරි fluids resuscitation with thiamine නමන වගේ ඒවා දෙනවා but you don't need to give steroids. හරි. Okay. Right. Now we move on to NASH, right? Non-alcoholic steatohepatitis කියන එක. හරි non-alcoholic steatohepatitis කියන එක. හරිද? Okay. Now in non-alcoholic steatohepatitis, again, there is no alcohol intake, but there is fat deposition. Now here, there are two slight differences. Here, the fat deposition is slightly lower than or smaller than alcohol, right? So in alcohol, you get something called macrovesicular steatosis, where the fat globules are big. In NASH, the fat globules are usually smaller, right? Smaller, podi eva thamai enne. Microvesicular steatosis, NASH. The other thing I told you is the fat deposition in alcohol is mainly around the centrilobular region. Here it can occur in the portal region as well as in the other zones, but mostly in the portal, around the portal. So periportal thamai enne. Right? Periportal and portal inflammation ennat puluwa. Portal inflammation ennat puluwa. Right. Okay. Fine. Now there is a spectrum of this non-alcoholic fatty liver disease, right? Non-alcoholic fatty liver disease. There is a spectrum. There is a spectrum. Right? Non-alcoholic fatty liver කියලා කියන්නේ just the fat. Just the fat කියන එක. හරි. But you can get the next stage, alcoholic hepatitis වගේ, non-alcoholic steatohepatitis, right? Where there is inflammation. And when me chart එක පොඩ්ඩක් බලන්න. හරිද? මේ chart එක චුට්ටක් බලන්න. මේ යටම තියෙනවා diagnostic criteria එකලමයි. හරි? In order to definitely diagnose NASH, you need to do a liver biopsy. Definite diagnosis එක කරන්න. Because NASH එකේ you see that ගොඩක් inflammation තියෙනවානේ. Fat deposition, lobular inflammation, and hepatocyte ballooning. So it says inflammation in NASH. Inflammation and maybe a bit of fibrosis. And NASH can progress to full-blown cirrhosis if you don't manage it properly. So, so non-alcoholic fatty liver disease is the big spectrum. Ekek podi sub-classification එකක් තමයි මේ කියන්නේ. Just non-alcoholic fatty liver is just fat deposition. මේක උඩට lecture එකක් කිලු ගන්න නෑ මම මතක විදිහට. NASH වල you get inflammation. එහෙනම් මතක තියාගන්න NASH කියන්නේ there is inflammation and you need to demonstrate the inflammation, right? Hepatocyte ballooning, lobular inflammation, you need to demonstrate that. And some people can get fibrosis. හරි? ඒක බොහොම වැදගත්. තව ලියා ගන්න so definitely diagnose NASH, always exclude other factors, other causes of fatty liver disease. Other causes exclude කරන්නත් ඕනේ. හරි. හරිද බලන්න එක. So that is what NASH is. අපි MCQ එකක් කරමු. True or false? Now this is referring specifically to NASH. So NASH කියන්නේ මොකක්ද? There is fat deposition. There is fat deposition, microvesicular fat deposition. Non-alcohol level microvesicular. Alcohol level macrovesicular. So microvesicular fat deposition, and I told you that the deposition is mostly portal, right? Portal, periportal. Not centrilobular, periportal. So microvesicular fat deposition. And I told you that in non-alcoholic steatohepatitis, you need to see evidence of inflammation also. To diagnose NASH, you need to see evidence of inflammation also. Hepatocyte ballooning and lobular inflammation. Predisposes to hepatocellular carcinoma. Yes, this is now emerging as one of the key risk factors for hepatocellular carcinoma. In some countries, more than alcohol-induced, this is now becoming a major leading cause of hepatocellular carcinoma. Ultrasound scan එක diagnosis එක කරන්න බෑනේ නේද? right? You need to do histology. NASH diagnose කරන්න histology කරන්න ඕනේ. Histology කරන්න ඕනේ. නැත්නම් diagnose කරන්න බෑ. ultrasound එක විතරක් diagnose කරන්න බෑ. Right? Because of the inflammation, ferritin is increased, right? In NASH, remember ferritin is an acute phase reactant. In NASH, the ferritin is increased. Right? Now, you know, ferritin is also increased in another type of liver disease, which is rarer, called hemochromatosis. ඒකේ ගොඩාක් වැඩි ferritin. මේකේ චුට්ටක් වැඩි because of the inflammation going on. Right? ඒක හරියද බලන්න එතකොට. එතකොට NASH කියන්නේ very specific entity, microvascular fat deposition in the mainly on the portal region. It also has evidence of inflammation and a definitive diagnosis biopsy එකෙන් තමයි කරන්න පුළුවන්. And there might be fibrosis also superadded on top of all of this. Right? It's inflammation. Because the fat, there is inflammation. Right? And now we have these various types of scans that can determine the degree of fibrosis. අපි කියන biopsy කරන්න ඕනේ කියලා. සමහරවිට අලුතෙන් එක scans තියෙනවා non-invasively ඔය fibrosis කොච්චර තියෙනවද අරක මේක බලන්න. ඒවා දැම්ම ඕල ලොකුට ඉගෙන ගන්න ඕන දේවල් නෙවෙයි. Right. So how do you manage? Very important. Diet lifestyle modification is mandatory. And මෙතන මේ MCQ එකේ හැම මම දාලා තියෙන ඔයගොල්ලෝගේ අර කලින් MCQ එකේ 5 වෙනි point එක. Fat reduction clearly can result in NASH regression, and weight loss can actually result in histological improvement. Right? So weight diet reduction තමයි කරන්නේ. Then drug therapy ගැන පොඩ්ඩක් තාම හරියටම ලොකු evidence එකක් නැහැ. ඒක drugs පාවිච්චි කරනවා. හරි ඒක drugs පාවිච්චි කරන දැනගන්නේ MCQ වලට අහන්න නැහැ ඔයගොල්ලෝගේ. Right? Statins are used sometimes, and people think that they are effective. Natural statins. Some people use this vitamin E වගේ දේවල්. Vitamin E. තව දැන් අලුතෙන් ඔය GLP-1 agonists කියලා තියෙන diabetes වලට දෙන ඒවා. Right? ඒවත් people are using now. But if you take the guidelines, හරියට firm sure එකට මේක හරියනවා කියන එක තාම debatable. But these drugs are used. Statins are used. Vitamin E is used, and also GLP-1 receptor agonists, right? උත්පාවිච්චි කරනවා දැන් for NASH. But ඔක්කොමට වැඩිය what is clearly established is that weight reduction is the most important thing. That is the most important thing, and can cause improvement in histopathological changes also. Hari, any questions? So what are the hypoglycemic agents we can use in cirrhosis in a patient with diabetes? So again, you have to be very careful when you're using oral hypoglycemic agents in liver disease because the risk of hypoglycemia is high. Again, I think one of the safest things is to use insulin because you can titrate the dose very carefully. Right? Metformin should be avoided in end-stage liver disease, right? Sulfonylurea, some of them can cause cholestasis. Things like tolbutamide can cause cholestasis, right? GLP-1 receptor agonist පාවිච්චි කරනවා, but the safety evidence is not there yet. So, insulin or nothing at all sometimes, right? Nothing at all, most of the time, nothing at all. Because liver disease blood sugar අඩු වෙනවා. සමහර අය sulfonylurea පාවිච්චි කරනවා, but very carefully you have to use them. Metformin is avoided, should be avoided, right? Okay. Thiazolidine should be avoided because they cause fluid retention, so that is contraindicated. Metformin is not used most of the time. Hari. ඒක තව එකක් මම metformin සමහර NASH වලට පාවිච්චි කරනවා. NASH වල all these about weight reduction strategies වලටත් පාවිච්චි කරනවා in NASH, and they sometimes improve the liver histology also. Okay. Right. Any other questions before we move on to the last part? Okay. Right. Now, these next few MCQs are focusing on, let me check, yes, hepatitis, viral hepatitis. Now, viral hepatitis is a slightly complicated, messy area. Hari. But you have to know the sort of key facts about these. You know that there's hepatitis A, B, C, D, E, no? Okay, put key points tika mama MCQ එක දාලා තියෙනවා. Right. 1. Chronic hepatitis and cirrhosis is seen in B, C, and D. Right, that is important. එක ලියා ගන්න. Chronic hepatitis, cirrhosis, B, C, D. Important fact. මේ කටපාඩම් තමයි කරන්න දෙන්නේ. Microbiologist mostly කටපාඩම් තමයි. Right, B, C, D. මේ ඔයගොල්ලෝ ඉස්සරත් මේ මොඩියුල් වලටත් මේවා කිව්ව ගන්න තියෙනවනේ. Right. Of those C has the highest risk of cirrhosis and hepatocellular cancer. මතක තියාගන්න ලේසිනේ C, cirrhosis, hepatocellular cancer, highest risk. Right. Okay, so first two MCQs done. Chronic is a common consequence of hepatitis A viral infection. The chronicity B, C, D, and C is the highest. So C, chronic hepatitis, cirrhosis, hepatocellular cancer. Tunama very C wala. C, hepatitis C. Right. And anindya magana hepatitis C වලම තව මොනවද? Hepatitis C is spread by blood and body fluids, and mostly IV drug use. Mostly IV drug use. Needle sharing. ඒකේ තමයි C ගොඩක් එන්නේ. B sexually transmit වෙනවා. C sexually transmit වෙනවා. But C mostly needles වලින් තමයි. Needle sharing වලින් තමයි ගොඩක් යන්නේ. ඒ ටික මතක දැන් C ගැන පොඩ්ඩක් ඒ ටික දැනගන්න. හරි. Hepatitis B and D go together always. Hepatitis B and D go together. Right? ये देखा एकटा इन्नो ने. D can't cause infection without B. Right. Hi. Okay. Now hepatitis A and E cause fulminant hepatitis, acute hepatitis. ඒක තමයි පොඩි පොයින්ට් එකක් තමයි 4 එකේ තියෙන්නේ. Hepatitis E infection is known to cause fulminant hepatitis in pregnancy. ඒක හරි. ඒක හරි. ඒක විශේෂයෙන් මතක තියාගන්න ඕන කාරණයක්. හරි. Okay. Okay. Now chronic hepatitis, chronic viral hepatitis, right? Chronic viral hepatitis B and C, there are lots of treatments now that can almost completely eradicate the virus, cure the virus out of the liver. B, C, ඒවා හරියම complicated, right? Those are really specialist. Infectious disease වල ඒවා විතරක් කරන අය තමයි කරන්නේ. හරි. Very complicated stuff. Lots of various antiviral medications which are now used in combination to treat chronic hepatitis B and C, and they can actually cure patients. Hepatitis C හැම සමහර cure කරන්නත් පුළුවන් with these new treatment options. මේ ටික පොඩ්ඩක් ඒ කාරණා ටික මතක තියාගන්න. Okay. Those are MCQ points that can be asked from these viral hepatitis things. Hari. Now, hepatitis B is a complicated thing because this molecule is arranged in this manner. There is a DNA virus, obviously, as you know, and there is a arrangement of antigens in the virus. So, hepatitis B surface antigen is around like this. There is a co-antigen, and they studded inside the hepatitis B surface antigen is this fellow called the E antigen. Hi. හරි මෙන්න මේක ටිකක් දැනගන්න ඕනේ මේක ඔයගොල්ලෝ මයික්‍රෝබයොලොජි ලෙක්චර්ස් කරනකොට උගන්වන්න නැති right. So hepatitis B viral infection serology එක පොඩ්ඩක් මතක තියාගන්න මහා මේක හරිම complicated area එකක්. නමුත් basics ටික විතරක් මතක තියාගත්තම undergraduates ලට ඇති. So hepatitis B surface antigen is positive in the early course of the infection. Plus, right, this IgM for the co-antibody. Sorry, co-antigen. Co-antigen එක මනින්න බෑ මොකද මේක අස්සෙනේ තියෙන්නේ. Right? ඒක මනින්න බෑ. We can measure the antibody here. Right? So in an acute infection, right, hepatitis B surface antigen should be positive and IgM for the co-antigen should be positive. ඒක අනිවාර්යෙන් positive වෙන්න ඕනේ. හරි ඒ දෙකම positive වෙන්න ඕනේ. Hepatitis B E antigen may be positive or negative. Positive නම් that means two things. One, higher infectivity. So in acute hepatitis B, if you have a hepatitis B E antigen positive, that can mean higher infectivity and severity. මේක මතක තියාගන්න. හරි. දැන් අපි යන් MCQ එක කරනකොට ආයෙක මතක් වෙනවා. හරි. හරි. So these are the things that are positive in acute hepatitis B. Surface antigen, co-IgM, E antigen, there's infectivity and severity. සමහරවිට අපි hepatitis B DNA එකත් බලනවා PCR කරලා. ඒක හැම වෙලෙම කරන්න බෑ. කරනවා සමහර වෙලාවට. මේක බොහොම වැදගත්. Right. True or false regarding hepatitis B? Hepatitis B is an RNA virus නෙවෙයි DNA virus. Right. Progression to chronicity is higher with infection in the neonatal period කියන එක හරි ඒක නිකන් කාරණයක් විදිහට මතක තියාගන්න. හරි. It can be acquired through the mother and the neonates who are affected have high risk of developing chronic disease. Right. Positive hepatitis B surface antigen is diagnostic of active infection keyword. වැරදි. Right? ඒක වැරදි. To diagnose active infection, you need at least two. What are the two? Surface antigen positive, IgM for co-antigen positive. ඒ දෙකම පෙන්නන්න ඕනේ active infection. Just because surface antigen is positive, that doesn't mean anything. Right? That doesn't mean anything. දෙකම තියෙන්න ඕනේ. දෙකක්වත් තියෙන්න ඕනේ. Preferably high viral load measured through PCR also. තුනම තිබ්බොත් තමයි හොඳටම diagnose කරන්න. Positive hepatitis B E antigen, mild disease cause නෙවෙයි ළමයි. E antigen positive, high infectivity and more severe disease කියන එක. Right. And acute hepatitis B වලට අපි antiviral therapy දෙන්නේ නැහැ සාමාන්‍යයෙන්. Chronic වලට දුන්නාට acute වලට දෙන්නේ නැහැ. Okay. ඔය ටික දැනගත්තා නම් ඇති හරිම now. Remember, hepatitis B causes chronic disease also. That is a very, very complicated area. I'm not going to even touch that. හරි දැන් මේ acute ගැන විතරයි නම් මම කියන්නේ ඔයගොල්ලන්ට. Hepatitis B, chronic hepatitis B is a very, very difficult area. Right? ඒක නිකන් ඔළුව කලබල කරගන්න එපා. ඒක බලන්නවත් යන්න එපා. විශේෂයෙන්ම now there are only few weeks to go to the exam. Don't try to understand it. It's extremely complicated and is far beyond undergraduate level. ඒ ගැන වාද වෙන්න එපා. Right? Very complicated. The antibodies and the various subtypes and naraka make a very complicated area. Right? If you know acute hepatitis B, how to diagnose, that is more than enough for me. Right? An exam point of view also for the moment. When you come to postgraduate, you can learn about chronic hepatitis B. Right. Right. ඔය ටික තමයි මම තව MCQ ටිකක් දාන්න infection කරනකොටත් about hepatitis, but this is essentially it. Sorry. Any questions up to now? I think දැන් අපිට ඉතුරුලා තියෙන්නේ yeah, best response MCQ ටික හතරක් තියෙනවා. Is there a vaccine for hepatitis C? They are developing a vaccine, not in clinical use yet. Right? Hepatitis B, there is a vaccine, as you know. A, there is a vaccine. E, I'm not very sure. B and A definitely yes. E, මං හිතන්නේ තියෙනවා. C is in development, right? There are trials and various vaccines. Try කරන්න ඒවා තියෙනවා. Okay. Any other questions? So hepatitis C, acute hepatitis C වල acute antiviral දෙනවා. ඒකට එක හේතුවක් තමයි අර චර රිස්ක් එකක් තියෙන එක ට්‍රීට් කරලා නැත්නම් progress වෙන්න. Right? Right. PCM overdose, usually not. Usually not. Chronic hepatitis, I don't. Cirrhosis, usually not. Right? Because people die if there is enough damage with paracetamol. Yes, hepatitis C is curable. Yes, hepatitis C is curable. It is. Yes. Based on the new, there are lots of genotypes. Hepatitis B, C, there are various genotypes. Certain genotypes you can completely cure hepatitis C with various combinations of complicated antiviral regimes. Okay, so let's go to the best response question one. The may prasnik 70-year-old man, pruritus, sarcomega. So cholestasis වගේ තියෙන්නේ නේද? Direct hyperbilirubinemia, ALP is high, නේද? Mostly cholestasis. So what is the answer? And the ultrasound does not show any biliary dilatation. I assume that you have put this as coamoxiclav induced drug. This is drug induced cholestasis. Right? And remember, සමහරලාට මේ මාසකට පස්සේ තුනත් එන්න පුළුවන්. that is a slightly unusual thing. අපිට මේක coamoxilab ගන්න කාලෙම එන්න ඕනේ එහෙම එකක් නැහැ. Sometimes can be delayed by 4 weeks to 6 weeks from onset. හරි. හරි මේක නම් එච්චරම වැදගත් නැහැ. මම නිකන් දැම්මේ පොඩ්ඩක් ඔයගොල්ලෝ ජිනෝම්ස් වලට මේක කියවගෙන යන්න. මෙන්න මේ ටේබල් එක බලා ගන්න. මෙන්න මේ එක එක various types of liver diseases in pregnancy. මේක මේ medicine වලට අදාළ හින්දා නෙමෙයි මම දැන් ජිනෝම්ස් වල සමහරලාට MCQ අහනවා pregnant related liver diseases ගැන. ඒතර මේක පොඩ්ඩක් තියාගන්න ඒකට. හරි. Right. 60-year-old woman with known alcoholic liver cirrhosis, abdominal pain, nausea අරක මේක තිබිලා තියෙනවා. Moderate ascites තියෙනවා and some generalized abdominal tenderness තියෙනවා නේ. Right. And there is a high acidic fluid white count. එක පේනවා bilirubin. So this is decompensated cirrhosis probably with ascites and SBP නේ. SBP. පහ. Right. 56-year-old female, hepatomegaly, diabetes, HbA1c 6.8, alcohol 15 units weekly, obese අරක මේක කතන්දර ගොඩක් තියෙනවා. hepatomegaly එකක් තියෙනවා. හරි. So ferritin is a bit high, AST/ALT is slightly high, and albumin is normal. හරි. right. දැන් මේකට උත්තරේ දැනගන්න නම් මොකද්ද කරන්න දැනගන්න ඕනේ? දැන් මේකේ පොඩි ප්‍රශ්නයක් තියෙනවානේ. මොකද්ද ප්‍රශ්නේ? මේක ඇල්කොහොල්ද non alcoholද කියලා කියන්නේ කියලා. හරි. So is this NASH most likely or is it alcohol related liver disease? What do you think? මොකද්ද? කෝ මේ වගේ MCQ අහන්නේ නැහැ මම නිකන් කියන්නේ මේ.
So alcoholic.
Why not? Why alcoholic and why not the other?
HbA1c is 6.8, so glycemic control is good, and the ALT is also higher than AST.
ALT is higher, Babu. AST, I mean, alcohol usually it's other way around. AST is higher than ALT. So there is one argument here that Vinu is pointing out. Yes, the HbA1c is good. But the problem is this patient is very obese. 36.2 can, that is morbid obesity. And this alcohol is just above this so-called safe limit, which now the cardiovascular people are saying there is no safe limit for alcohol use, especially when it comes to cardiovascular disease, right? So this is a difficult MCQ, and you can argue either way, but just above the safe limit of alcohol use. So 14-15 units and very obese. So I would say most likely this is mostly NASH, but MCQ you can argue for either, but make a boda Badipura Barai NASH, especially because the AST should be high if it's more alcohol, right? And then also this patient is just drinking barely above this so-called safe limit and is obese. Right? Okay. So, but this is not the sort of MCQ you get clear-cut answers, so don't worry. Right. Okay. Right. So today we have covered hepatology. Hari. Hepatology. Jaundice approach to jaundice, cirrhosis, alcohol-related liver disease, and non-alcoholic liver disease, and viral hepatitis. පොඩ වචනයක් දෙකක් ලියා ගන්න මේ acute liver failure ගැන. හරි වැඩි MCQ අහන ඒරියා එකක් නෙමෙයි යෝක. නමුත් ඒක ගැන චුට්ටක් නිකන් වචන දෙක තුනක් ලියා ගන්න. Acute liver failure. The commonest cause of acute liver failure by far is paracetamol. No doubt. Commonest cause by far is paracetamol. Right? Take a palliative. Right? But remember, it can also be due to viral hepatitis or autoimmune hepatitis. Right? Okay. One of the most sensitive markers of acute liver failure is PTINR. Right? That is the second thing. So if you have an acute liver failure patient, one of the key markers, earliest markers is PTINR. දෙවැනි එක. තුන්වැනි එක, in acute liver failure, they get multi-organ failure. Multi-organ failure, if you don't treat it, especially they get hepatic encephalopathy, renal dysfunction, and coagulopathy. ඔය තුන තමයි එන්නේ. Hepatic encephalopathy, renal dysfunction, and coagulopathy. Right. Last thing, management is conservative most of the time. Except if it's paracetamol, N-acetylcysteine, then the right? And some people are trying N-acetylcysteine for other non-paracetamol induced acute liver failure also. There is no clear evidence that it works, but some people do try it. And if you have seen, sometimes they do give it. When hepatic failure giyama nak denawa. But evidence is not very, obviously not firm evidence, but paracetamol definitely yes, but other ones also non-paracetamol acute liver disease, some people give N-acetylcysteine. A දැනගත්ත මතින් supportive management. Okay. Any questions from gastroenterology as a whole? So we have done 3 important medicine topics now: cardiovascular, respiratory, and gastroenterology, and hepatology. Any questions?